So before we get started, because this is a collaborative effort and it's taken a lot of stakeholders for us to get here, I'd like to recognize the participating provider groups and our BI firm that we've been working with to measure the results as well. So first, from Baylor Scott & White Health Texas Provider Network, if you guys would just stand up a second. We have Dana and Micah. Next, from Catalyst Health, we have Dr. Joe Lambert, who you'll hear from in just a moment. Then we have Texas Back Institute. I believe they're right here. Trish Bowling. And then also from Spine Team Texas. I'm not sure. There you go. Thank you. And we really appreciate the work these guys have done with us over the last several months in our work stream meetings, and they've taken a lot of time and effort to partner with us in this. And last but not least, from Cone Health, we have our group of data analysts, Jeff Hayes, Dominic, and team. Thank you. So with that, I'll introduce the panel. We have Annette King as our moderator today, and Annette has more than 25 years experience managing employee benefits for large and jumbo employers, including 9 years at Starbucks up in the Northwest. Although she's currently an executive director at Ernst & Young, she's actually here today with her employer hat on. So from her days at Starbucks, she was a founding member of the Puget Sound Health Alliance, a nonprofit dedicated to improvement in medical outcomes, and a past member of the Virginia Mason Board of Governors. On the panel, we have Doug Riley, representing the local voice of employers for the group today. Doug's the benefit director at JCPenney's, and he's also a board member of the Dallas-Fort Worth Business Group on Health. Doug has actually been a seasoned HR and benefits professional who's been involved in management and administration of benefits and compensation since 2001, and he brings a broad perspective to his role with his prior experience in healthcare and large health systems, or hospital systems, excuse me. Then we have Dr. Joe Lambert, who is board certified primary care physician and medical director at Catalyst Health Network. He's also president of his group at North Hills Family Medicine, and he's involved in physician relations as a medical director of Catalyst Health Network and also medical director of Innovative Infusions in North Richland Hills. So we're certainly glad you had time to come and be with us today. And he's going to be providing the provider voice today. And then lastly, we have Lamont Thomas, who's the Cigna president and general manager for North Texas and Oklahoma since 2012. And he serves as a senior leader for Cigna operations, competitiveness, and market growth in his region. He brings over 2 decades of experience in healthcare industry to his role. And Lamont was actually in the very first meeting that we had related to IQ Healthcare last year, along with some of his peers from other health plans. He was very supportive from the start, as well as his peers, who encouraged us that as employers, they felt like this was the right path for us to take, but they also cautioned us that if we started down this path, that we did need to finish. So we've considered that important from the start. Cigna was actually the first to provide the de-identified market data, which you've heard us talking about throughout the course of the year. So Cone Health has that. He's here representing the health plans today. We're also talking more about data at the end, but we would be happy to recognize as well Aetna, who's provided their data as well, and Blue Cross's is in the midst of being transitioned this week. So we're really thrilled to have those 3 health plans collaborating with us in this initiative. So with that, Annette.
Thank you so much. So I've been asked to just share with you my experience in the Pacific Northwest with Virginia Mason Medical System when I was with Starbucks. But before I start that, and I need to stand, that's kind of who I am. Let's talk about 2004. 2004, we saw a quote this morning in session number 1. In one of the slides, it said, "The right goal is to improve value." So that's really what's going to weave through, I think, this discussion today. Also, back in those days, Dallas-Fort Worth area was also one of the most expensive markets. So you are still in the same place you were. Doesn't sound like there's been much progress, which is unfortunate. Also think about in 2004, that was 3 years before the iPhone was launched. Does it give you a little bit of perspective? Doesn't that feel like forever ago? So hopefully we can make a little faster progress in this market. That's what I'm hoping we can get out of today. The other thing that was going on in 2004 was that there were a set of employers in Seattle in a room talking about 3 particular provider groups. Virginia Mason was one of them. And we were discussing the fact that they had the highest cost as compared to other providers on a number of key specialty areas, one of which was low back pain. We were having that all too familiar conversation that employers have of, do we kick them out of the network or do we let them step in or stay in? We had such organizations as Costco, Alaska Airlines, Starbucks, King County, City of Seattle, Nordstrom's sitting in the room having this conversation together. And we didn't want to kick them out. A lot of our executives used Virginia Mason. You guys have been in that position, right? The noise, we don't want the noise. We don't want to go tell the CFO he has to change his doctor. And so we took the position that we were going to ask each of these 3 provider groups to come in and tell us what they were going to do to reduce their cost and to get back on the good list in order to win the right to remain in the network after a year. Because they were not only going to have to tell us what they were going to do, but they were going to have to measure it, and they were going to have to prove to us that they had amended their ways and become a more competitive provider in the marketplace. We had those sessions. It was interesting. One didn't demonstrate to us, but VM really tried hard, and we were getting a little frustrated because we weren't feeling that they really got the issue, because what they were presenting to us didn't make a lot of sense, and we couldn't see how that was going to drive down our cost. And during that conversation, we had the question, well, who is your customer? I said, well, the patient. I said, well, what about us? We pay the bill. We pay 80% plus of the bill. Are we not your customer? And that's when they sort of had their epiphany, and things got better from there. So we had a collaborative, and Virginia Mason came to me. They called, they made an appointment with me, an appointment that worked in my calendar, not theirs. And Dr. Mecklenburg appeared, and he said, we want you to help us get better. We want your feedback on how we're providing care. And we're thinking one of the ways to do that is to target a specific condition. And would you be willing to talk about this and work with us? And I said, okay. I haven't had this experience before, but I'm open. And he said, yeah, we're thinking heart conditions. I said, my average age is 26. I don't think so. How about low back pain? And he said, low back pain? I said, yeah, my imaging's going through the roof. It's increasing 25% a year. I'm not getting any healthier employees, and my spend is skyrocketing, and I have a lot of it, and I want it to stop because I know a lot of it's not necessary. He said, low back pain it is. And that's how we began. We were formed in 2005. We had our focus on uncomplicated back pain. Again, imaging was increasing, employees directed to specialists. Benefit managers out there, how many of you have received the call that says, my back is killing me, I can't get into work, I've got primary projects going on, and I was just told that I need a referral, and when I call that physician, it's 2 months before they can see me. How many of you have had that experience? And then they say, help me get an appointment. I need to get fixed, right? Yeah, long waits for care. Lost productivity, that person is sitting at home in pain, wanting to work, can't work. And so we started the collaborative. I got appointments on my calendar, and I went to Virginia Mason's clinic, and they had all the appropriate team members. They had finance people, they had administrative people, they had physicians, and they had personnel from their spine clinic. And we started just talking about the problem and saying, how are we going to go about this? What does it look like? And one of the first things that Virginia Mason did, because they adopted the Toyota Lean methodology, is they mapped out what does a typical patient experience look like. And you can see that, in case you didn't get it, it's the really colorful slide, right, on the right-hand side. All that pink and yellow is wait times and waste. Only the green at the end provided any relief to the patient and treated their low back pain. Now, again, we're talking uncomplicated here, but it would take nearly 60 days for that patient to get to the right care. You're paying for all that waste, and your employees are suffering through for up to 2 months before they're getting the care they really needed. At the end of the collaborative, the slide on the left, same day or next day access. Their very first appointment, they're assessed to confirm it's uncomplicated, and then they move immediately into their first PT session while they're there. No referral to the physical therapist, then scheduling another appointment and waiting 2 more weeks. And no, you're here for your back pain, you're in, no MRI. We were just talking about the RX cost, over the counter. The amount of cost removed from this system was pretty significant. So we had some goals when we set out. We set some quality standards, evidence-based care, 100% patient satisfaction, same-day access, rapid return to function, and affordable price for both the buyer and the seller. So we didn't expect them to deliver this reduced care or this appropriate care at a loss. And so that did come into our conversations, and some pricing adjustments were made, because when we stripped out that MRI, they started losing money. They weren't going to keep doing that. They weren't going to keep doing the right thing if they were going to lose money at it, right? So this is where a collaborative comes into play. We're all learning from each other. We're all discussing what all of our challenges are. Now, it didn't happen overnight. I learned an awful lot about their internal systems. I learned what it took to change behaviors within their organization, both from physician behavior, appointment management, et cetera. But it was worth it because it lowered our cost. It lowered the volume of treatments. It got my people back to work a whole lot faster. And that worked for all the other employers in the Seattle area, because Virginia Mason didn't do this just for Starbucks people. They changed their way of doing business for all of their patients. So everyone benefited, the entire community. Now, you may say, well, what did VM get out of this? Their MRI usage dropped from 43% to 8%. I heard later that they actually got to postpone buying a secondary MRI machine that was in their capital budget because they had created so much capacity through this initiative and another initiative. And whether that was true or not, I don't know. But their margins were also 3 times higher than their prior model. Couple of other things, let's see. I believe that they were able to treat 5 times the patients than they had prior to this with less staff. So they had a lot of wins out of this, a lot of wins. I had a lot of wins. My peers had a lot of wins. So it all evolved around meeting once a month. Now Virginia Mason and Aetna, who is the health insurer in this activity, they had homework. I know that they did a lot of work behind the scenes. Virginia Mason had to make changes to their appointment scheduling, their MRI system. They actually had to put in what at that time felt very draconian to them, but they had to put in gates to prevent unnecessary MRIs from being ordered for uncomplicated back pain. But their physicians adjusted. And those things took time to implement, to communicate, to roll out. But within a year, we had completely changed the model and the care stream for uncomplicated back pain at that particular clinic. Now, that didn't stop there. My peers that were in that room in 2004 each took another condition, and I believe 4 conditions total were done. Migraines was one of them. This was another one where MRI delivery for migraines dropped from 50% to 5% of the cases. Pretty significant. And you can see here a number of other programs that Virginia Mason then continued to work on after these initial collaboratives were done. So they valued the results so highly that they said, we're just going to keep on going. Now, what's really interesting is that Intel then took the work that we did with Virginia Mason with low back pain, and they imported it into their Portland, Oregon area, along with some of the local governments. And they had 2 health systems that joined them in that activity, and a different healthcare provider or carrier got involved in that. And so it continued to spread outside of Seattle. Boeing then also adopted it. And when Boeing adopted it, they were able to convince 2 other Seattle-based health systems to get on board as well, which was something that we weren't able to do at the onset, even though we tried. But Boeing's buying power. So what I want you to take away from this is you do have a lot more buying power if you come together, employers. You have a strong voice. And I understand that the Business Group on Health here has, 750,000 lives in this area? That's a whole lot more buying power than I had when I worked with VM. So you can do this. You can do this and it will pay off. Chest pain was the last one. So with that, would like to jump in and chat with these fine gentlemen on what's been happening here locally.
Thanks, Annette. I think for us, as representing the board of directors for a Business Group on Health, we started a couple of years ago in our strategy session, kind of wanting to move away from more of the informational setting that the business group had been historically, and start talking about some of the things we can do to leverage the buying power, as Annette had referenced. And we wanted to be focused and find a specific condition. We wanted to do something that had been done before and done successfully. So we kind of landed on the lower back pain, and that's exceptionally bad when we start looking at our usage in Dallas-Fort Worth compared to even other markets. It seemed to be the obvious outlier. So we started down the project. We wanted to be collaborative. We wanted to bring the provider groups and the health plans with us, because I think that a lot of the challenges with the current system were created not only just by health plans and providers, but also by employers. So I think it's going to take all 3 of us working together to come up with the right solution. And I fully expected, as being in healthcare previously, a lot of resistance, and I was blown away by the collaboration and the willingness to change from the health providers. I spent a lot of time with the Texas Back Institute, and one of the eye-opening experiences when I first showed them what the total cost of care was for a lower back surgery, they kind of been focused on what their costs were. They had no idea of all of the costs that was really going into that lower back surgery. Some of the fraud, waste, and abuse that's out there. A lot of times there was other things other than the surgeon getting, or the hospital even getting, the largest reimbursements. So I think the huge opportunity is, how do we better effectively use those dollars? And it's really employers' dollars. So that has been kind of the focus of our efforts. And I think at this point, we have the initial groups that were mentioned by Danita at the beginning have been on board and they're participating. We're just now getting the data. We're starting to get our hands around trying to set the baseline so we can measure the results and start to provide some effective solutions. Solutions may vary by employer. So I think it could be just as simple as educating employees that providers A, B, and C are going to provide higher level of care. It could, may ultimately be as much as plan design if you want to, have a plan option or all of your options that steer towards the higher quality provider. So maybe it's a tiered benefit approach. At the end of the day, though, I think when we really focused on what we're trying to accomplish, there was a huge amount of variation in the care that was being delivered. So not everybody handled lower back pain the same way. When you take out the variation in care and really focus in on what makes sense and kind of take a supply chain approach to managing that care and getting the right care as quickly as possible, I think that's when we started to see the real results show up. Mm-hmm. So better outcomes, better cost, better quality.
Yeah. So Joe, what's been the physician response to this activity?
I think it's been very positive. First of all, I'm a primary care physician, as she said, a family medicine physician in North Richland Hills. This activity is very new to me. I've never been to any of this kind of a collaborative event, and I think it's just an amazing thing that we're all getting together and talking about all of these things. And I want to at least somewhat provide you a perspective as a full-time practicing physician in primary care, what we experience within my independent practice and what we experience as part of a larger collective of independent practices that have come together as an ACO, Catalyst Health Network. Back pain and low back pain, we see it all the time. I see a lot of scars. I see scars on my patients, but they're not better, right? They had multiple surgeries. They're no better than when they went in for the surgery to begin with. And so something's wrong. You talk about the total cost of care, how that adds up, how that impacts our communities. It's something that we as primary care physicians had not previously maybe been aware of or cognizant of, but now we are, and we're on board. And we really feel that the way that we practice medicine and how we want to make it all about the patient and about the doctor-patient relationship and making healthcare evaluations with each patient in a shared decision-making process, whereby each decision, say it's low back pain, is made with our patients in a logical, a goal-directed, evidence-based way and an unbiased way. That's what we're all about, whether it's low back pain or it's diabetes or it's depression, it doesn't matter. We have to make science-based decisions at the time of our visits, and we want to be accessible to those patients so they can be seen in a timely fashion. And then from that point, protocols will work, I believe, more so now in this environment as part of an ACO, because then we are hooked up to Catalyst Health Network and we can take these decisions and we can operate within a framework and a flow whereby we refer our patients to the appropriate cost, the imaging centers, and the referral patterns which are congruent with what we're trying to get with our patient. We want to get our patients healthy, faster, and efficiently. And now as a PCP and now being part of an ACO, I have that kind of information about the specialists that we use, about the imaging centers that we use, and it's really interesting and fun and cool to be part of that process as a larger quality and performance entity. You think about low back pain and low back pain protocols. I saw a patient about 2 weeks ago. This is you have to take the whole patient into account. This was a lady who is my patient. She's in her late 40s, active, healthy lady who called and needed to see me because she was having really bad low back pain, left low back pain. So we want to be accessible, so we had same-day appointments. Yeah, come in to see me for a walk-in. So she came in and she was telling me about how severe her back pain was. Now I know this patient and I know her mother. I knew her mother. Her mother had passed from a lower abdominal and pelvic cancer, and this patient had a significant family history of cancer, including bone cancer within her family. So I kind of knew where she was coming from. And she's like, Dr. Lambert, this really hurts. I think it's cancer. I need an MRI. I need a CT. I need labs. I need some tumor markers. Help me out. And it's like, well, hold on. Let's evaluate you and figure this out together. And so, well, okay, you didn't injure yourself at work. Doing pretty good. It appeared uncomplicated. Exam looked good. Urine specimen's fine. Okay. So I have to, at that point, we make a decision together with the patient to take a conservative approach, and I'm giving this patient instructions. Okay, I need you to trust me. I need you to watch for these signs and symptoms, watch for A, B, and C to occur, and then come back and see me on Monday. We, in PCP world, we want to be accessible to this patient. So yes, you can call me at any time. We have on-call services. We have access to your medical records. We're here on Saturday. We have extended office hours if you need to come in sooner. But let's see how this goes conservatively. And she came back Monday, and she was all laughing and smiling. I'm like, oh, wow, that's great. Miss Smith, looks like your back pain's all better. And she was like, no, Dr. Lambert, it hurts terribly. I'm in a lot of pain. I said, oh, okay, well, what's going on then? She said, well, over the weekend I discovered I have this rash here on my side, and I looked it up on the internet, and I have shingles. And so it's like, oh, really? So looked down, and it's like, yes, indeed, you do. You have shingles. That's awesome. And so never been so excited to diagnose my patient with shingles. So, we gave her medicines, and then we sent her on her merry way. But this is sort of I guess an example of what we in primary care try to do. We work with our patient. It's a shared decision making process. We want to be accessible. Had that patient gone through the pathway of low back pain, then we have a conservative way that we can do that. We use a Rosti Physical Therapy Centers. They're right across the hall. I could have sent her to that. Let's say she had something more significant. She really did need that MRI. We have the capability and knowledge to send this patient to the appropriate in-network services where she can get a lower cost imaging. And if she needs to see a specialist, I know the orthos, I know them, I know what I expect from them and what I expect for them to give my patient. So if we had done those tests, let's say on that day, let's say we had done the MRI and the CT in the labs, we wouldn't have diagnosed shingles because you can't diagnose it that way. But we might have found a whole bunch of other incidental things. Let's look, maybe a little cyst on the kidney or something. And then the radiologist says, oh my goodness, now you need to have your patient come back in 3 months for another test. I'm sure that's benign, but we have to have them come back. So now I have to tell the patient that, and then the patient is extremely worried and concerned about that for the next 3 months. What does that do to her work performance and her sleep and her immune system? Who knows, right? So these kind of things I think are important, and it's important for us all to collaborate. We just in primary care really believe in the doctor-patient relationship, and Catalyst gives us these additional layers of care to augment that. And now I think this is really, really cool because here we are today talking about this protocol, how it was successful, and we're talking with employers, and we're talking with payers, and we're talking with vendors, and we're talking with specialists. We all have the same goals. And I'm just really excited to keep talking about this and take this talk to action, within the Metroplex. There's a lot of room for us to improve.
Mm-hmm. So Lamont, providing claims data, that's fantastic. So why was it important for you to participate and share that data for this project?
Thanks, Annette. Well, actually, Dr. Joe just gave me a new idea, create a network around websites where you can do self-diagnosis and cut the healthcare costs real far down. But no, and Annette, based on our experience, the Cigna working with our collaboratives, and we found that it was important, as Dr. Joe and Doug had mentioned, providing the data and working to understand what is that data telling us and how can we use that data more effectively. And so when Dallas-Fort Worth Business Group and Health brought us all together and talked about this is a time now where as employers, we're going to get off the sideline. We're actually going to participate in developing a solution that's local, that we value, that we want to pay for. And that became important because prior to that, it was really all about the hospital systems, the physicians, and the health plans like Cigna going and building a solution, what we believe to be the right solution, going to the employer and said, how about this? No. So we run off and we do something else, bring it to the employer. And it's like, no. So now we're at a point where come down here and sit at the table here with us and let's build this to something that you see value in. It has transparency. It's focused on quality, which is key element, and that was critical, that it had to be focused on quality. And then if we can do that together, then we save a lot of time. And we can put out something that you guys value as payers, the real payers in this equation, and something that also, more importantly, the patient, the employee, the customer finds value in as well.
Mm-hmm. Yeah, great. So Joe, where do you see employers playing a role?
I think it's important employers, have an understanding about, and this is where it gets into the local part of it as well, because just kind of backing up for a minute, it's of all of our primary care physicians who are part of Catalyst, a lot of them are stalwarts within their community, and so they understand. They know the businesses, they know the churches, they know the schools, they know the general geographic distribution and parameters within the areas that they serve, and they've been doing so for a long time. So there's that unique kind of a quality which I would be hopeful that we could provide to, say, employers who were, within those regions as well, and having discussions between the employers, even within geographic distributions, like, okay, our patients are 26, or our employees are 26 years old on average, or maybe they're older, they're more likely to have these kinds of problems, and then we kind of talk, these are the kind of issues that we're having, okay, here we are in primary care, let's develop a protocol that may be specific to even certain areas, make it more exact. That could, I think, be very successful. And of course, at the same time, you know, focusing on a larger, you know, footprint, which we at Catalyst are proud to say that we have, you know, over 500 providers covering over 900,000 lives, you know, and that large footprint is really cool. But I think it's very, I think it's a good and maybe necessary thing to have the local flavor and the discussions between employers and the physician groups in primary care. And just, you need to do it not once, but multiple and over, and keep bringing it up.
Mm-hmm. No, I think that's a good point. I know when Intel took the back pain stream from VM, they did adjust, and they had the two healthcare systems, and each implemented it a little bit different because of their own environment. So I agree. You can have that overall, but then you have to adjust, and the geographic areas make sense to me as well. Yeah. So, Doug, here we sit today.
Mm-hmm.
Let's imagine we're in this same conference 3 years from now. What would you want to be talking about at that point? What's your vision?
I think it'd be really cool 3 years from now if we could say, you know, we changed the way healthcare was delivered for lower back pain, and hopefully it expanded into a few other, you know, as they had in the Northwest. I think that'd be amazing to me, and I think we could probably do it in a way that makes sense makes it better for providers, and makes it better for the health plans, and definitely makes it better use of the dollars and resources that employers are putting into the marketplace. That'd be the ultimate goal.
Wouldn't that be cool?
Yep.
Yeah, instead of, I think I came and spoke to a group similar to this probably in 2010 or so, and I would love to come back in 3 years and hear about all of those successes. So if we could just take a couple of minutes, Lamont, I'll start with you. What's sort of the one or two things that you would love for this group to take away and think about over the next few days?
And one of the things I would like the group to take away is that we're in a time of major disruption in the industry right now. And in a disruptive time in an industry, there's innovation. But let's be cautious about some of the things that are being brought to the table to you, make it as solutions in healthcare. You know, really make sure that they're evidence-based in a lot of the things that they do, and that they make sense. I mean, a lot of things we want to say that are tied to technology and apps, and we all have them, so there's nothing wrong with apps, but that's not the end-all solution. Healthcare is a very personal relationship business, and folks want help, and folks want to engage with their doctor, and there's accessibility. They want the doctor. So as we building solutions, we need to think about the end user. That we can't have one solution fitting everyone. It's really a focus around one. We're working on the affordability, but let's not forget about the personalization. That not everyone with diabetes is the same. And to your point, Dr. Joe, not everyone with lower back pain is the same, so we can't treat everyone the same. We got to understand their family history. We have to understand the situations they're going around, that are dealing with just day-to-day life. And then the other aspect that we need to think about is how do we engage the behavioral aspect of what's going on in healthcare. Yeah, lower back pain is a problem. You know, cancer is one of the high cost areas. We think about the impact of diabetes, but underlying to all of that are behavioral type of challenges around depression and things like that. So as a healthcare system, we need to figure out in our solutions, how do we deal with things like depression, as an example.
Great, Joe?
Yeah, I'd like to piggyback on that. Agree with both points there. You know, it's something we see every day: depression, behavioral health issues. There's huge gaps in that, and that's what we call comorbid condition. Anytime they have that and they have other stuff, their conditions just get worse. And so I don't know exactly how, but I believe there's a lot of ways that we can work together to improve that dynamic, and that may have really, really positive results, I think. So I want to bring that, I want to bring that out as well. And I do agree about the personal aspect. I think, you know, I don't know, if I'm an employer and I have employees, I want them to be able to see a good primary care physician who has the tools to take care of them and who really cares and who works with them and is they're very accessible, right? And then just lastly, just this continued collaboration and working together to find answers. To me, like I said, it's my first time in a thing like this. I find it very uniquely amazing, and just excited to be here.
I think I'd go back to the point you made earlier, Annette, that I think the more participation we get from the employers in the group and the business group is going to accelerate this or decelerate. So I think that's really the key to me is can we get more employers involved in the process? And I think it can be very collaborative. It doesn't have to be confrontational.
Absolutely.
Yep.
Yeah, and I think my request of everybody, the employers in the room, it can initially, at least I'll share my experience. It was initially a bit intimidating to think that a physician with their level of education, their experience, you know, we've been raised to really respect that profession, to have them say, come in and we want to hear from you, was a little intimidating. I remember that first meeting, I thought, I don't know what I could possibly tell these people. But what's really fascinating is they were very open. They wanted to hear what our challenges were. They wanted to hear what our experiences were. And I was able to bring sort of more of that common business stuff to the table that wasn't as everyday because they're delivering healthcare and not really running a business. So we learned from each other, but also don't be afraid. Just because you haven't done it before, it's really not that scary. And what other thing could you do right now? Invest an hour a month, plus a little drive time if you have to go to meetings off-site. But an hour a month to go out and meet with the collaborative group, contribute, and it's not creating a budget item in your benefits budget, so you don't have to talk to finance about it, right? There's no funding you have to ask for. You're not going to end up cost shifting anything to your employees because you're spending an hour a month. It has benefits. It benefits your employees because they're able to get access faster. They're able to get the right care and get rid of the waste, which they're probably cost sharing in, right? Not only are you losing money on the waste, but they are as well. And they're losing precious time when they're going to appointments that are unnecessary and receiving tests they don't need. So how else could you know, what a great lever, what a great thing to be able to go and do, and it costs you nothing but an hour a month. The people who really do the heavy lifting, quite frankly, are the providers and the health plan, because they always come away with each meeting with a ton of homework. Okay, now I've got to go research the evidence-based medicine. You know, the health plan is going away and say, okay, now the provider needs the health claim experience at this level of detail, not that level of detail that I initially provided. There's the takeaway of, well, what can we change in the admin system in the hospital that will enable us to drive the activity the way we want it to go, so we can make sure our physician providers are aligned with the care stream and not requesting unnecessary tests. And all of those other things that they have to do, they actually do the heavy lifting, employers, but you've got the voice and you're the one spending the money. So please, 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 I hope that you will recognize that an hour a month is not that big of a lift. And quite frankly, I think I did it maybe a year and a half start to finish on the low back pain, because then we started diving into disability and work comp, and you know, it went all sorts of places. But it's a very easy investment when you think about the payback. So I think the first year VM saved us over $100,000 with this change. So an hour a month for $100,000, yeah. So Donita, are you ready to go?
Questions. I got a text while we were working, and I think Dr. Connard, who was our medical director for the project, you may have a comment as well.
Yeah. So real quickly, one of the things that I got to go to all the meetings with all the providers as the corporate representative, and one of the things that kept coming up that I just kind of broke my heart, but I wanted to share with the corporations in the room is, and it came out different ways, but many of the rooms I'd be in, they'd take me aside after and say, Scott, do you think that something's really going to happen with this? The groups that volunteered for this are really highly ethical groups that want to take great care of people. And one of the things that's breaking their heart, in fact, Spine Team Texas's leader, Dave Rothbart, literally said, I'm so tired of watching people who are doing the wrong thing to patients get paid 3 and 4 times what the doctors who are trying to do things right are getting paid. Do you think the employers are ever going to do anything to actually support the doctors who are trying to do things the right way? Because right now, what they're doing is they're giving a blank check to doctors who are not ethical and are not doing the right things. And the Texas Back Institute that worked with us on this, one of their lead doctors said, it's so sad to me when I see a patient, I say, surgery will not help you. And they say, but I'm in pain. And they go next door to basically a poor doctor who says, sure, I'll do surgery tomorrow. What's your day look like? And it happens day after day after day. And unless the companies will put some, what did you call it, Annette? Gates in place to actually have the person slow down and have the kind of experience, maybe their shingle pops up, it's not going to happen. And it's got to be driven by the employers because you have the checks. So that was a sentiment that these doctors, Baylor shared the same thing, and the leaders of Catalyst did, is if we could get the companies to actually help us be rewarded for being the best doctors, or just help us do the right thing and not have people get hurt by the system.
Thank you, Dr. Conrad. And one question that came in, which I think is probably for you, Lamont, can we as employers directly pay a provider that we deem to be high quality, or does that violate our TPA agreement? You're welcome.
Thank you. You sure that wasn't for someone at Aetna? No.
I'm sorry, it was anonymous. I don't know.
No. So as a self-funded company, you can build your plan to meet your needs.
Okay, so they just need to contact you if they're
Yep,
with
we can
Cigna
talk
and they
about
have a
it. That's
question.
right,
All right,
exactly.
perfect. So, all right, any other questions from the crowd? All right, any other comments from any of the other project team members or participating providers, Virginia? So that's Virginia Nesbitt. She's our benefit strategist on the project.
And I've been in the corporate world on the benefits side for a good number of years. One of the speakers earlier talked about employers are kind of at their rope's end in terms of having levers to pull. I do think it's pretty clear that we do have a big lever at our fingertips if we, as employers in this marketplace, can all get behind this initiative and as it expands to be able to do something really remarkable in this marketplace. And I think that's what Annette was alluding to, but I think what we can't do individually, I'd absolutely believe that we can do collectively. So I hope you will be interested in learning more and helping us kind of steer towards the next condition or the next few conditions that are high on your list so that we can truly be having an impact in this market. Because I do believe, I'm very encouraged, the providers want to work with us, the health plans want to work with us. This is a really unique opportunity for us to make some headway.
Thanks, Virginia. Any other question? Am I missing anybody's hand? All right. So if you'll flip us to our call to action, Annette, just for 1 second. You've heard loud and clear throughout the day, actually, for employers to get more involved. And we want you to leverage your collective scale. As Annette said, we have about 750,000 lives in this market that the group represents. Direct or really channel your employees to participating providers for IQ Healthcare, and we're at the table right outside. We can talk to you further about that. We'll also be following up with you throughout January or December and January. For employers in the room, you received an email from Marianne right after Thanksgiving that had the link to the member site with the toolkit. You may have also noticed, if you've looked at our IQ Healthcare site lately, there's a financial calculator that can help you calculate your opportunity for savings in this area. For providers, we encourage you to review your process of care. Go ahead and just keep populating in that. Heighten focus on quality and patient safety, and just continue to collaborate with us. We've had several great groups already. And then from a health plan standpoint, collaborating with us, eliminating waste and variation. Other ways to improve patient safety, offer ways to improve patient safety and quality, and as we replicate to other conditions, help us expand. From a data standpoint, I mentioned this earlier, but as we've got the data coming in, We're going to be moving into that measurement phase. So again, you'll be hearing from us probably the first part of the next year with the first preliminary benchmark and starts of results. If you're currently with a health plan that isn't sharing data and you'd like to see them participate, then please talk with your account rep. We also have sample language that we've sent you guys before as you come up for renewal. If you're interested in having some additional data ownership language, we found some that some have found helpful. And then also just continuing to collaborate with us to improve quality in our market. Thank you very much. I guess this ends our session. And Marianne? Yeah, we're going to break, I think, Marianne.
Okay, very good. Thank you all for participating in the panel. We will go on a break now for about 20 minutes, and then we'll come back.